Hello, everyone. I'd like to welcome you to our discussion today about donor management. This is the Amplify Donation and Transplantation Summit of 2021. And my name is David Rowe. I'm the current Chief Medical Officer of Indiana Donor Network. I'm also a pulmonary critical care physician. I was the director of the IU Health lung transplant program for about a decade and transitioned into a more of a suburban-based pulmonary critical care practice, which enabled me to become the Chief Medical Officer of Indiana Donor Network. And so I'm also in charge of the donor management for all of our donors, both on site here at Indiana Donor Network as well as at other hospitals across the state, whether it's a brain death donor or it's a DCD. So today we're just going to talk a little bit about the donor management process, which is obviously totally dependent on you all, especially being at the hospitals. When we move a donor here, Indiana Donor Network, obviously the on-site coordinators do most of the management, but we're still managing about 40% of our brain death donors at outside facilities, and obviously all DCD and pediatric donors are being managed in your hospital systems. And so we're very dependent, and we appreciate all of the help that you give us. So obviously it does take a team like anything else in medicine. It's very hard to do things by yourself. Just so you know how many organs can actually be transplanted from a donor. As you can see, you obviously do the heart, both lungs, the liver, pancreas, both kidneys, intestine. You can do multivisceral transplant as well. So really, you're looking at 8 life-saving organs from just one donor, which is really outstanding. And that goal cannot be reached without the integration and the cooperation that occurs between Indiana Donor Network and healthcare providers across the state. So I just want to give you a little idea about organ transplants in the United States, so how many are done per year. You can see roughly about 40,000, 35 to 40,000 transplants. The majority of these are obviously kidneys, with liver coming next, and then it really drops off with heart and lung, which is a little bit more of a difficult transplantation process just due to the donor themselves. You can see very few pancreas, pancreas, a little bit more common than pancreas transplants, and then intestine, and very few heart and lung transplants are actually performed across the country. Normally you can transplant most of those disease processes with either just a lung transplant or a heart transplant. Most of the heart-lung transplant patients are usually severe pulmonary hypertension or some other congenital process. So I think it's important to just go over the definition of different donors. You hear these acronyms thrown around, and it's important for you to understand, I think, the difference. So DCD is donation after cardiac death. So that's why the patient remains in your hospital and remains on your service. So they've suffered some devastating, catastrophic, irreversible brain injury, but they're not brain dead. But withdrawal of that therapy could lead to their brain death and lead to them dying. Usually that DCD process is within 90 minutes, but in some centers it's being pushed out to 120 minutes sometimes. Obviously, brain death is when they have complete irreversible cessation of brain function, which is confirmed by not only a physical exam and clinical diagnosis, but sometimes confirmed with a ancillary test like a cerebral blood flow or something along those lines. Sometimes an apnea test can be performed if the donor is stable. But it's important to understand these differences because those donation after cardiac death or DCD donors will stay in your facilities. So obviously when we come on site to help manage donors, we need your assistance. In fact, we really don't have privileges to enter orders when we come to your hospital. And so therefore we depend on the nurses, physicians, secretary, et cetera, to help us facilitate order sets. And these order sets usually contain basic management guidelines and basic management orders that we normally do for the average donor, including antibiotic coverage. We use a lot of piperacillin, tazobactam, cefepime, vancomycin. But sometimes if your donor has had a previous infection or active infection that you've been treating, we will not modify that. Obviously, there's a lot of diagnostic testing. There's both lab work, there's CT scans, chest x-rays, cardiac catheterizations, biopsies that need to be done sometimes if there's suspicious lesions. And so those will be within the order sets. We're going to talk a little bit more about lung management, which is what we really focus on quite a bit from my perspective, whether it's ventilatory changes, whether it's bronchoscopy or arterial blood gases, things like that. Obviously, if your patient does not have access, we would need central venous catheter, art lines. We really don't use Swan-Ganz catheters anymore. We can use non-invasive monitoring if we need to. And then obviously management of other medications if the patient is hypertensive, hypotensive, if they're in shock, management of their urinary output, fluid management, and then very important to manage their electrolyte abnormalities as well as to control their glucose. So I think it's very important, and one thing that we focus on with every donor is looking at donor management goals. And I've kind of outlined these up here for you. This is like a perfect scenario where we have a donor whose mean arterial pressure is within a normal range. Their CVP, central venous pressure, is at least low to normal, so they're not volume overloaded, especially for flooding the lungs and increasing total lung water. We want their ejection fraction for cardiac donation to be normal. Try to keep their pH within a normal range. Glucose usually less than 150. We want to maintain urine output, PF ratio, and then actually sodium we'll talk about for liver donation. But the bottom line is that we're treating these donors just as you treat them, right? I consider a donor to be a patient. And so we want to manage that patient so we can maximize the gift of life through organ donation. And if we are not attentive to their needs and we're not pursuing them aggressively as we can, then we're doing a disservice to both the donor and the potential recipients. And so you can see the little summary at the bottom that you're just trying to keep them at a normal temperature, keep their volume normal. You want to be aggressive with pulmonary toilet, preventing aspiration, treating infections. So it really is just everything that you all do at the bedside almost every day in the critical care units. So there is some literature available to support these donor management goals. There's actually a plethora. If you get on PubMed, you can find quite a bit. This is just one that was kind of caught my eye because it looked at extended criteria donors. And right now we are trying to not just go after the perfect donor, but go after these extended criteria donors, which may be an older donor. You have multiple comorbidities, maybe the smoking history, drug use, or hepatitis C positive, things along those lines. And so those are considered extended criteria donors. And even focusing on the donor management goals of just achieving these can result in a higher organ transplanted per donor rate, which is really what we're going after as well, right? We want to maximize the number of organs we can have per donor. So as you can see, a little caveat at the top that, there's 90 people in Indiana alone just looking for a heart transplant. And we have multiple heart centers here in the state of Indiana who can perform heart transplant. But some of the basic allocation or management of the heart you can see is electrocardiograms, getting an echo in a timely fashion. Sometimes we may ask for a repeat echocardiogram if the initial EF is low based on the catecholamine storm or some of the pathophysiologic effects that occur from brain death, or if they had a serious neurologic injury. Then we will try to treat that over a 12 to 24-hour period, repeat an echo, and then get a catheterization if need be. It's very important because sometimes we'll see a stunned myocardium or a stress cardiomyopathy, and then that can resolve over time with treatment, and then we can donate that heart where initially we were not able to. Obviously, you're going to manage these patients with inotropes and pressors and maintain their mean arterial pressure, and et cetera. So as you can see, allocation of the lungs, what we're doing now is kind of talking about each organ per se. There's close to 1,000 people waiting lung transplants. As we talked about before, there's only about 2,400 to 3,000 of these performed per year. So really what we do with the lungs is we try to get on site, establish what the initial PF ratio is, and then do some aggressive maneuvers either through PEEP recruitment, ventilatory mode changes, bronchoscopy, pulmonary toilet, using nebulizer-based medicines, antibiotics, maybe repeat bronchoscopies. Actually, we've started proning donors now. I think most of you probably prone with the recent pandemic with COVID. And then patients with acute lung injury, ARDS, proning has been shown to decrease morbidity and mortality. And so there's actually a few good studies out now looking at proning with donors. And so we will aggressively move down the path of trying to prone these donors if we're able to. So some of the goals of management from a lung perspective is a PF ratio greater than 300, modifying that with PEEP and FiO2. Want to maintain a good PCO2 and pH balance. One thing we're focusing on a lot now, and a recent study has shown this, that the compliance of the lung really predicts success in transplantation. So we're trying to keep the plateau pressures down, we're trying to keep our driving pressures down, and trying to maintain at least a normal compliance, which I think a lot of centers are now looking at compliance and the entirety of the lung versus just what is the PF ratio. And similar to ARDSNet ventilatory strategy, we use low tidal volumes at 6 to 8 milliliters per kilogram. Sometimes we'll go up a little bit higher than that if the peak pressures can tolerate. But the majority of the time, we don't want to induce volume trauma with having too large a tidal volume. So you can see that with an initial O2 challenge and follow-up or ABGs, we've developed an algorithm over the past year, and the on-site coordinators will follow this. We normally do this with our brain death testing, or brain death patients, and not DCD. With DCD patients who are spontaneously breathing, it can sometimes be hard to do aggressive lung recruitment and management. So we really need to work with you at the bedside, especially the respiratory therapist and the physician, to figure out the best way that we can handle that. And these are just some of the things that we'll ask, both on DCD and that we'll do with brain death, is keeping the head of the bed, maybe using reverse Trendelenburg. We do have a lot of obesity in the state of Indiana, and so sometimes just raising up the bed, you can actually cause a decrease of excursion in the chest. Obviously, you want to check the pressures in the tracheal tube cuff, aggressive oral care, and just things, like I said before, things that you're already doing. So allocation of the liver. Liver transplants are obviously much more common. The liver is a tough organ. It can handle a lot of insult. One thing we do try to focus in on is the sodium. There's been some research looking at higher levels of sodium can actually cause increased bleeding and decreased liver function after transplant. Quite a few livers get biopsied before they're transplanted just to make sure there's nothing there that you can't see just grossly on a CT scan or when they're actually procuring the organ. And obviously, as you're maintaining the heart, you're maintaining the lungs, obviously the liver and other organs will obviously benefit from all of that with good perfusion, oxygenation, etc. What's very interesting about liver transplantation, as you can see at the bottom, is that sometimes you can split the liver. So not only can you transplant one patient, you could potentially do a second patient. So with the pancreas, we really just try to keep good blood sugar control. Sometimes we'll use insulin drips, which you can. That really doesn't hinder pancreatic transplant. And it's difficult. You can see that sometimes the pancreas itself, when you're procuring the organ, you'll sometimes take a portion of the small bowel as well as the spleen, so you're not directly handling the pancreas, causing an indirect pancreatitis or something along those lines. There's quite a few folks needing kidney transplants. As you can see, just in Indiana alone, it's almost 1,000 folks again, compared to 1,000 patients across the country who need lungs. It's 1,000 patients almost in Indiana. The kidneys themselves usually are able to be donated, which is great. We now actually pump all our kidneys here at Indiana Donor Network for 24 to 48 hours, where you can actually you can measure the flow and the blood flow and the perfusion and et cetera. So even if a patient has renal failure, they even could be on CVVH, you can sometimes take those kidneys, help them recover by pumping them, and you can still end up placing them, which is really remarkable. So being on CVVH or having an elevated creatinine does not preclude us or prevent us from trying to procure those kidneys and actually have them transplanted. So as we said, we really don't do very many intestinal transplants, but you certainly can. Really has the same thing with the pancreas and the other organs, is just maintaining good electrolyte balance, fluid management, and things along those lines. Recently we did do a multivisceral transplant where you can take multiple abdominal organs and transplant them into one recipient. So obviously, some other things you may see in the order set, we obviously greatly depend on the bedside nurse. As I said, we treat the donor as a patient. If we need to maintain normal thermia, whether it's through cooling blankets or heating the patient up, it's the typical nursing duties of I&O intake and et cetera. The monitoring of the ins and outs is critical as far as being able to manage the lung appropriately with total lung water, inducing diuresis. Plus, a lot of these donors will develop diabetes insipidus. So their urine output may be tremendous. And so we need to replace that. We need to treat that with vasopressin, need to monitor the sodium closely. So those are the things we just need to be aware of. So in conclusion, I know a lot of this is some things that you already do at the bedside, and a lot of it depends on the coordination between Indiana Donor Network and the healthcare providers. I'm very big on bedside communication. When I manage these donors, the on-site coordinators, we're sometimes FaceTiming. We're communicating fairly frequently about management decisions and how things are changing. I know it can be a very stressful situation when you're dealing with grieving families. You're under a time constraint trying to help us coordinate and get to the operating room, which can be a strain on the healthcare system. I think that's one of the reasons we like now bringing donors to Indiana Donor Network, so we can kind of decompress your ICU beds, your operating rooms, and things like that. But Without you and without your dedication to organ donation and to helping recipients, we just couldn't do our job, and we couldn't do it as well as we're doing it now, that's for sure. So I greatly appreciate all of your help and assistance. I hope this has been somewhat enlightening. It's some kind of behind the scenes look at things we're doing. And by all means, if you ever have questions or there's issues, you can talk to the on-site coordinator. I'm on call 24/7 all the time. You can always get a hold of me as well. So thank you for your attention.